Welcome from Washington, D.C. I'm Chad Ramsey, Vice President of Policy for the Ovarian Cancer Research Alliance. And below me there is
Vanessa Kramer. I'm Director of Policy and Advocacy for Ovarian Cancer Research Alliance. Great to be here, Chad.
We're really grateful that you stopped by our session. We hope that it will be informative, and it's a really interesting topic. So we're going to try to go through everything. I'm going to let Vanessa do most of the talking, but I'm going to interrupt her constantly to try to interject when I have questions or when I think that there might be questions that you might have during the presentation. But here's the topic that we're getting into today. This is how to talk about genetic testing and precision oncology and why it's so confusing. It's a topic that we've really been focused on for the last year or so, and it's been becoming more and more relevant in the cancer space.
That's right.
So here's our agenda.
So we're going to kick things off by setting the stage. Nothing happens in a vacuum. And so we're going to talk about the series of events that have brought us to where we are today. These are the big developments in precision medicine and how they impact our patient population. Then we're going to talk about how compliance with genetic testing guidelines has been in our community among ovarian cancer survivors. Then we're going to unpack the issue and talk about maybe some of the reasons that compliance isn't the best. And then we're going to take a look at what's happening in other cancers. And lo and behold, the same thing is happening in other cancers as these new technologies are being brought into the mainstream and used more and more. So then we're going to talk about the working group that we became part of and the charge for this working group, which was really to delve into the issue of how we're talking about testing, if we're using the right language, if we have a set of common definitions and understanding around this language. We're going to talk about the process and what we found in doing a deep dive within all of our respective communities as a working group. We brought back our findings, what they mean for the community, and then we're going to zoom in on where Ca125 testing fits into all of this, because there's potential for confusion there when we talk about genetic testing and biomarker testing. And then we have some great visuals that we came up with as a working group. I personally am a visual learner, and I think a picture says 1,000 words. So we've got those to recap everything. And then we offer you some resources as well as our contact information for any follow-up. And I will add, don't be shy. This is, I think as Chad noted initially, this is a topic that all patient advocacy groups have been scratching their head about for a while. And this is part of the reason that this working group was convened, part of the reason we're doing this session. So please don't be shy about any follow-up questions, no matter how silly or small they seem.
That's right. That's right. And just to give you some insight, our organization itself has been struggling with this and making sure we land on the right terms. So if you as a patient advocate or a new ovarian cancer patient are confused about the terms, you should feel that you're in really good company, because the whole community hasn't quite gotten on the same page. And so that's what we're trying to do, trying to get people on the same page so that we can all talk about this type of testing properly and make sure that it gets covered, make sure that you know what to ask for so that you can get the best treatment possible.
That's right. So here we have setting the stage, what brings us here today. So over the past 20 years, BRCA1 and BRCA2 related discoveries have profoundly changed our understanding and management of HBOC, which I'm sure all of you know stands for hereditary breast and ovarian cancer. Now, importantly, these genes, BRCA1 and 2, were really the pioneer mutations when it came to connecting the dots with cancer risk and cancer management. So shortly, this was in the late 90s when they were initially discovered. And fun fact, Dr. Mary Claire King discovered the BRCA genes. She went to my alma mater, University of Washington, and she spoke at our national conference last year in Seattle. So obviously she's a hero in our community. So that was great. Anyway, after the discovery of these genes, this was groundbreaking. Guidelines from NCCN, SGO, ACOG, all leading medical professional societies quickly followed. And they agreed that anyone with a personal history of ovarian cancer should receive genetic counseling and testing. Now, bear in mind that these guidelines have changed and are slightly vary from each other insofar as what scope of genetic testing one has done, and we'll get more into that later. But this was all kind of around the discovery of BRCA1 and BRCA2. Those were the main genetic mutations. So when these guidelines were issued, they meant at a bare minimum that any individual with a personal history of ovarian cancer should get genetic testing for BRCA1, BRCA2 mutations. So these guidelines come out, they've been in place for well over a decade at this point. They were some of the first to be issued in the cancer space when it came to genetic testing. So then we had the Affordable Care Act, which was being crafted in 2009, 2010. This was when testing for BRCA1, BRCA2 mutations was really sort of brought into the mainstream because our legislators were figuring out if genetic testing should be included as part of the prevention health benefit under the Affordable Care Act. So at that point, too, we were thinking of genetic testing for these BRCA1 and BRCA2 mutations as really part of the prevention health paradigm. So we were thinking about how it's applied, how information can be used to screen for cancer risk and prevent cancer. It was less about management. It certainly wasn't about testing in family members. It was really the beginning of all of this. So the ACA brought this idea of genetic testing for BRCA1, BRCA2 mutations into the mainstream for HBOC. And then we had, and it's really interesting because we're now starting to see a lot of this research be published. I'm sure a lot of you remember when Angelina Jolie, she received testing for BRCA1 and BRCA2, and she had preventative surgery. She went public with her story. And this, there was a huge uptick in public and patient interest in this type of testing. You saw patients in droves go to their doctors and ask for it. There's a lot of research now that indicates maybe some of the prevention surgeries that occurred as a result of this testing may have been unnecessary, but it's interesting because it definitely is a phenomenon that is now the source of study. So all of these things sort of coalesce to bring us where we are today.
And I think that was a what, 2013 when Angelina Jolie came out with that information and had the prophylactic surgery. So right, that did have quite an impact, and we've heard, being in the organization we hear a lot about the impact that had. So it's really interesting, and I think that it's important to note that as far as we know, that it's about 10 to 15% of ovarian cancer patients have a BRCA mutation. But it's also important to note that we don't really know what that number could be because of the under testing that is performed. So it's possible that number could shift the more women who have tests for that mutation moving forward. But we know it's at least 10 to 15%.
That's right. And the other thing that's really not mentioned on this slide, but is a recurring theme here, is the pace of the precision medicine field is moving so quickly. So as these things are happening, we're seeing all of these wonderful innovations in the private sector around different diagnostic tests. And these diagnostic tests have varying scopes. Some of them look for a handful of mutations, others are more comprehensive. But we're seeing this shift in technological capabilities follow. So it's a really exciting time. And I told Chad in preparing for this that the last time I looked, and now the trend is in guidelines to veer away from really specifically defining how many mutations should be screened for some of these tests. because the number of mutations we're discovering connected to specific cancers is really growing every year. And last I checked, I think SGO indicated a couple of years ago, and this was the most recent information I found, but that comprehensive testing, genetic testing for inherited cancer risk includes 12 different mutations. So we've really grown leaps and bounds beyond the days when it was just about BRCA1 and BRCA2. All right, so Chad touched on this in the previous slide. So tons of studies have been done since these guidelines have been in place, and since ovarian cancer was one of the first. There's a whole wealth of evidence and research, and all of it is not good, to be honest. It all indicates that in our population, there are big barriers to receiving testing in accordance with guidelines. And that really is something that informs the session and informs a lot of different policy initiatives we've been involved with at OCRA, because while all of these different innovations are super exciting, especially now that we're screening for more mutations, and now that we're testing not just for inherited genetic mutations, but also for acquired genetic mutations, and we'll get more into that down the road. But here there's been this explosion of different tools, and they're only valuable if patients are using them. And so what we started seeing is that while on the innovation side, a lot's being done, on the patient access side, patients just aren't accessing these. And so there's lots of different research that suggests different causal factors. And, we have certainly been collecting anecdotal evidence over the years from what we hear about our patients. It seems like, on balance, there's been a failure to really integrate genetic counseling and genetic information and genetic testing into the clinical care paradigm in oncology generally, so it often falls through the cracks. There are, of course, coverage issues. Some insurance companies don't cover this testing, even though these patients are eligible for it, and it would be in accordance with guidelines. There's also some apprehension at the patient level that we've heard about. But we've also heard about it seems like such a silly thing, but just the simple fact that patients don't really know what tests they should be asking for. They don't know if they've had these tests. And, navigating a cancer diagnosis is overwhelming in its own right. So there's a lot of different causal factors there. But all of these studies and all the research agrees that testing rates in our patient population are alarmingly low. This is in spite of the fact that these guidelines have been in place for over a decade and were among the first to be issued. So last year, in a groundbreaking study, this was, and I do have to do a due diligence, a plug, because we are on the policy advocacy side and based here in DC, but a groundbreaking study that was funded by National Cancer Institute, and this is why NCI funding is so important. Last year, this study was published in Journal of Clinical Oncology, and it represented the first population study of hereditary cancer, so all hereditary cancers, hereditary cancer genetic testing in the US with laboratory confirmed results. So, in the past, because the data hasn't been that great, there's been a lot of modeling, there's been sort of small sample sizes, and this was groundbreaking because it was the largest and the first of its kind. So it really is what we call in the public health space a baseline setting study. So using data from more than 83,000 women from SEER cancer registries in the states of California and Georgia. So the SEER cancer registries are run by NCI, that's National Cancer Institute.
Yeah, that stands for Surveillance, Epidemiology, and Results.
That's right, Ramsey.
And it's really the gold standard for cancer statistics that the NCI runs. And so the SEER data is what you'll see used for just about every really important cancer statistic that is out there.
That's right. And so what we found is in 2013 and 2014, and just to give you some context, the Affordable Care Act, that benefit we spoke of, that provided genetic testing for people at risk of developing HOBC, that benefit went into effect in 2014. So, and really other things started moving into the mainstream. So it really is, it's also a recent data. So this study found that in 2013 and 2014, roughly 1/3 of women with ovarian cancer underwent genetic testing for inherited BRCA1 and BRCA2 mutations. So when we talk about these guidelines that have been in effect for over a decade, those are the bare minimum. All guidelines agree that BRCA inherited genetic mutations for BRCA1 and BRCA2, this should be part of genetic testing for all ovarian cancer survivors. So this is not being done. That's woefully out of compliance under low rates of testing. That's not I don't think anyone had any idea that testing rates were quite so low. NCI did a big blog on this study. There was a lot of coverage of this study. It really rang alarm in our community and also just in diagnostic testing communities, because the big takeaway was we're not doing our jobs and these patients are not getting these tests. And now we know too, it's really not just about screening and prevention. Now information from these tests, it's used to manage treatment and care, to inform decision-making. Now we've got this whole new class of therapies, these targeted treatments that are for people with specific genetic mutations who have ovarian cancer. So these tests are really critical to determining eligibility for all of the different treatment options. They're also important in informing cascade testing in family members and relatives, which is definitely an important piece of this. So we found that the study found that 1/3 of ovarian cancer survivors got genetic testing in compliance with professional guidelines. And then the other piece, the other top finding here for those who might question the value of getting this genetic testing. And again, this is the bare minimum BRCA1, BRCA2 genetic testing for inherited germline cancer risk, that 15% of those tested had actionable genetic mutations, meaning that this information was valuable in guiding their treatment and care. So that's really huge. So this is a valuable quote, or a quote from this groundbreaking study by the lead author, a couple of different quotes. And we want to be crystal clear here as an organization that has been steeped in this issue for several years now, that the research doesn't identify a single causal factor as to why compliance rates in the ovarian cancer population are really low. It just says clear as day, they're really low, and this is an urgent issue. So these quotes get at some of those causal factors, and it set up things for this working group we're going to talk about next. So I'm going to read them. Genetic testing has become quite cheap and accessible, and this study includes a time period when it was becoming much cheaper. So it's striking that we still see low rates of testing. I think it suggests that there are most likely other barriers outside of cost. The study also revealed racial and socioeconomic disparities in testing rates among women diagnosed with ovarian cancer. Genetic testing rates were far lower for Black women than for white women. They were also lower for uninsured patients than for insured patients. So that really is not all that shocking, right? Because what we're discovering is even people with pretty robust health plans who are insured are having access getting these tests, or having issues getting these tests covered. So here's a final quote here. These findings have uncovered a disparity gap that is much more substantial than I would have thought. So, and this is an echo of what all of these expert researchers who have looked into this have said. Wow, these findings are even worse than we thought. What is the issue here?
And it's really hard for me to place too much blame on the patients because this is, a situation where you've just you've just heard this diagnosis, and you're being filled with information, and you feel like you're taking it in from a fire hose, and you have some expectation that the care that you're receiving is top notch, and so you wouldn't think, oh well, I need to make sure that I need to request biomarker testing, or I need to make sure that there's germline testing to determine hereditary risk. Those aren't the first things that pop into your brain. And so we think that there are a number of factors, but I feel as though, you shouldn't feel put off or down by the fact that you don't know exactly what to ask for immediately upon diagnosis. We're here to try to help you with that information, to try to make sure that you have the best possible information and talk and the way to talk about it with your provider that will make things easier for you and make sure that you're getting the best standard of care treatment.
Yeah, just to dovetail that, the onus, it's always been our organizational position that the onus should not be on the newly diagnosed patient to figure all of this out. But unfortunately, that seems to be the reality. So our solution in all of this is to provide you with the tools to best position you to advocate for yourself in this space that is changing really quickly. So meanwhile, what's happening in ovarian cancer over the past 2 decades has also been happening in other cancer spaces. And as we touched on previously, the number of applications and uses for genetic testing has grown across the board in oncology. So it's really not just about prevention and screening anymore. It's about treatment, decision-making, and risk management. It also informs risk of developing a secondary cancer. And for our patients in particular, one of the big benefits to genetic testing is determining whether or not a patient is eligible to take PARP inhibitors, which are targeted therapies for people with specific BRCA mutations. And I should add to that what we're seeing generally in cancer medicine as part of this whole precision oncology movement is that cancer treatments are less toxic and more targeted. So cancer is really shifting to almost being treated like a chronic disease, which is great because our goal, of course, organizationally is long-term survival for all women diagnosed with ovarian cancer. So even to understand if these new therapies will work for you requires this battery of tests here.
And beyond even whether you are eligible for it, I mean, we're seeing label indications grow particularly for PARP inhibitors beyond specific mutations, but they really help design what the therapy should be, what the course of medicine should be. Is it a combination therapy that will be best for you based on your genetic information? And your BRCA mutation. So there's a lot of data, not just for eligibility, but for the management of your therapy that can be gleaned from these tests.
That's right. And I should note too that, because ovarian cancer, we have identified so many genetic mutations associated with ovarian cancer. All of these different mutations serve as potential therapeutic targets for new therapies that might be in the pipeline. So it's really important to be aware of the mutations in your cancer. All right, so here we're seeing the same confusion happen in other cancer spaces as this type of testing moves more into the mainstream. We're talking to longevity, we're talking to the pancreatic cancer people, we're talking to Force, we work rather closely with them. So we're talking to all of these other patient cancer organizations and identifying a pattern that our patients don't know which test to ask for. We're also reaching across to different stakeholders, talking to the pathologist, talking to some of our industry partners, and they're finding that adoption rates or compliance rates with guidelines that call for genetic testing are low in other cancers. So a pattern is developing. It's not just ovarian cancer. And it makes sense, right? Because this space has moved at a breakneck speed. And I will also admit that I think Chad and I had some anxiety about entering into it because we don't have science backgrounds ourselves, and it is kind of intimidating to peel back the layers. So last fall, all of this is to say this was the precursor for the multi-stakeholder working group, which we call a few different things. I don't think we've figured out like the leanest, meanest name as a coalition, but right now it's the Consistent Testing Terminology Working Group. This is a consortium of 41 members that includes all of these different stakeholders with an interest in ensuring there is a set of shared definitions and consistent terms when we talk about these testing modalities and genetic mutations. So the working group's aim is to identify and adopt consistent terminology and a common language around biomarker and germline genetic testing and precision oncology across cancer types. And we're going to get into what this means for some of the nuances around ovarian cancer and Ca125 testing down the road. But this working group, I guess it convened about a year ago. I want to say the first meeting was October of 2019, thereabouts. Anyway, we just launched a website where we've posted our white paper, which is the culmination of the past year's work. And we'll talk about what that process looked like on the next slide. But this white paper includes recommendations for moving forward and will also include other updates as we work to educate patients and really pull our findings into the mainstream.
So yeah, if you really want to get into this, you go to Common Cancer Testing Terms.org and read that white paper, because it will really delve into some things a little bit more deeply than we're able to get on this presentation.
So here are all of the different working group members. As I said, there are 41 in total, and you can see and this is how you know you're among a good crop, you're in the right space. You can see that it's heaviest weighed towards patient advocacy groups. So two things to emphasize here that are important, that all different types of cancers are represented. So we really were aiming for that pan cancer. We just knew that if we were going to be successful in having a common language, it would need to be used across cancers. So that's one thing to highlight. The second thing to highlight is the different types of stakeholders. We really, and this is a nod to Nikki Martin at Longevity, who ran this working group and continues to and does one hell of a job. But we really, we have all of the important players at the table. In particular, we've got the National Society of Genetic Counselors, right? This is their bailiwick, how you talk about this. We also have the pathologists. So those are the lab people, the Association of Molecular Pathologists. We've got everyone who has a stake in this and also has a really defined role in the care paradigm when it comes to cancer. Everyone was involved. All right, so this is just a quick slide to summarize our process here. So as a first course of action, all of the patient advocacy groups were sent the charge to survey their respective constituencies to figure out what terms are being used right now to discuss biomarker testing, to discuss tumor profiling, to discuss the umbrella, all of the different types of genetic and genomic testing. Here we know that we're all speaking different languages, often to refer to the same type of testing, but this survey really drilled down on what these specific terms were that were in use, and also from the patient side, what the barriers are to understanding the meanings of these words.
So Vanessa, can you think of any of the terms that were identified during this process to describe some of the testing that's done now?
Sure. So we found germline genetic testing is something that people are using when they are meaning to say tumor profiling, right? Or getting their tumor genetically tested. Somatic testing is another one. Molecular tumor profiling is another one. All of these words are kind of used interchangeably. And what we did find, especially in our population, was a point of pride, was there is a better understanding of what constitutes germline genetic mutations. So these are your inherited genetic mutations versus somatic. Those are acquired as part of your tumor. But where things get dicey is in how people are requesting these tests. So, and Chad and I talked about this at the beginning and whether or not we should touch on this if it may cause confusion, but testing for inherited genetic mutations, theoretically, that's a blood draw and you would need that once because those mutations never change. That's your germline mutation. What gets a little fudgy and why it is so important that we are all speaking the same language here is when the scope, the number of mutations that the test looks for changes, right? But your germline, those are the genetic mutations that are inherited. Those never change, those stay static. But biomarker testing, that's something that is subject to change because that looks at your acquired mutations. All right, so here we've got over 30 different terms swimming around across the cancer spaces. And so the next thing is, what are we going to do with this? How are we going to make heads or tails of this? And how are we going to make it meaningful? And so in looking at the findings, we settled on 3 umbrella descriptor terms. And between these 3 terms, we think that you should have a baseline understanding of the testing universe as it applies to your ovarian cancer diagnosis and treatment management. So the first term is biomarker testing, and this term is used to discuss tests that identify characteristics, targetable findings, and other test results originating from malignant tissue or blood. So this can be both on the tumor side or it can be a blood draw, right? But this is categorically, this biomarker testing is used to describe either or. So that's one term. In the second term, and these terms can be used interchangeably, genetic testing for an inherited mutation. So these are the first generation tests we saw, right? The BRCA1, BRCA2 test that we spoke of at the beginning of this presentation. So that can be used, or genetic testing for inherited cancer risk can be used. These are the same types of tests. And we did it that way because we found that in equal parts, both of those terms are used currently. And as far as, defining those terms, they make sense. Everything squares with them. They are what they purport to be. So I think a lot of you might already be using those terms. So that's good news for us, at least from sort of the anecdotal evidence we've collected over the years from our patient population.
So terms 2 and 3 can be used interchangeably. They basically mean the same thing. They're just 2 ways of describing it, right?
That's correct, Chad.
Now, under what category would you place NGS tests, next generation screenings? Where would that fall?
The Foundation 1 test, the liquid biopsy test. So that would be a biomarker test. That would be number 1, right? Because that is looking at your tumor tissue for somatic acquired mutations. And that's also subject to change.
Great.
So this begs the question where Ca125 testing fits in.
Now, this is a very familiar test for most of our patient population. And when we get together with our advocate leaders and other groups of patient advocates, they're very comfortable and familiar with Ca125 test, which is a cancer antigen that tests the amount of antigen that's in your bloodstream to determine how much the cancer is shedding, and it can let you know if there is a possible recurrence.
And if you'll remember in the past slide, for this bucket of biomarker testing, we were specific in saying that can be for either tumor tissue, right, or blood testing. So with Ca125 testing, because as Chad says, this is a blood draw, you're looking for proteins that are shed in the blood, that would be a biomarker test, right? So the working group really sort of grappled over this, and we settled on the following. So traditionally, we have viewed biomarker testing as non-genetic, and thus limited to things like Ca125 testing. So this is where there is potential for confusion, because a lot of patients are like, I've always called my Ca125 testing biomarker testing. How do I differentiate? So in thinking about this and in looking at our survey results and in sort of reading the tea leaves for the directions of the future with everything, the thought process is that the more salient distinction is not so much whether something is genetic or non-genetic, right? But whether something originates from the tumor tissue, the malignancy, or from the germline. So if it's germline, it's fixed, right? What might not be fixed in the test is the number of mutations that are tested for, but your germline testing results are always going to be the same. Those are your inherited mutations. The more we get into the field across cancers, we think that that's the most important thing that patients understand, is that difference, whether something is germline or somatic. So the thinking is that using these umbrella terms, and the next slide goes over what that actually looks like in discussion, that yes, that if you add this qualification, so we're asking cancer types this applies to, which of course is our cancer type, and a lot of other cancer types use Ca125 or similar antigen tests, that you just add that qualifier, right? So Ca125 testing is still biomarker testing, and we don't want to confuse that, because that is our bottom line message, that it's all biomarkers, and that's legitimate, that's true. So it's still biomarker testing, but we're asking that we start to use the qualifier there, because the field is exploding. Things are getting more complicated. So to just tag on the words for Ca125 would be the way that you would talk about that going forward.
Yeah, and I hope that I mean, if you ask your doctor or what your Ca125 levels are, that is sufficient. But when we really want to help to educate the entire patient population about the importance and the value of molecular tumor profiling, so we wanted to make sure that people understand the how to talk about biomarkers, which is why we're trying to be so granular here. I think it will benefit us all when we think about the Ca125 as one biomarker, but there are many others that can be tested, particularly with NGS screening.
That's right. That's right. And that takes us to the second bullet, which is when it comes to molecular tumor profiling, these are your liquid biopsy tests. This is the Foundation 1 test. That's so amazing. You could say biomarker testing for molecular tumor characteristics. That gets at what Chad says it is. It's all biomarkers, but we're asking for those qualifications, just the bigger and the more complex the field gets overall. So that would be how you would differentiate. And I do want to emphasize what Chad said, that your provider, a lot of this, I think, probably is most useful in talking to fellow survivors and in talking to your care coordinator, or in getting things straight for you. Your provider, I should think, most people, as Chad said, are very well-versed in Ca125 testing. But this is just a way to level set and delineate across cancer communities. So, and then that last bullet there is be sure that you're using genetic testing for inherited mutation or inherited cancer risk. So just to solely describe germline testing, I think we've emphasized that a lot. All of the landmark study we spoke about at the beginning of the presentation, and all of the subsequent studies that show that genetic testing is low in our patient population. These are especially worrisome, right? Not only because the testing's low, but also because this is only looking at one type of genetic testing. It's only looking at the genetic testing for inherited mutations or cancer risk. So it doesn't even get to the NGS testing or the molecular tumor profiling. Chad and I have discussed that, unfortunately, there's not a lot of data to indicate where testing levels are when it comes to molecular tumor profiling. And the anecdotal stories and evidence that we've gathered over the years suggests that there are a lot of barriers. I'm sure testing rates when it comes to biomarker testing for molecular tumor characteristics are even lower.
Yes. We're about to boil this down for you to make it a little bit easier. That's right. So I found that these slides to be pretty helpful.
Yeah, so the first one, these are some visuals that the working group developed. And again, hats off to Longevity and the National Society of Genetic Counselors who have really been carrying the water here. But that first square there gets at the specific. When we said that 33 terms were identified across cancer populations, these are the specific terms we found. And of course, there was overlap in how different groups were defining them. But some are really small, but others, you can see biomarker testing, germline testing. These are the types of things that patients were asking their providers for, and possibly thinking that they were getting one test when they were asking for another. So that gives you a flavor for some of that different type of language. And then the middle square there says inconsistent cancer testing terms create confusion. And I think this has been an overarching theme, but confusion specifically about what kind of test should I ask for? What kind of testing have I already had done? Did I get the right test? And what does the test mean for my care? These are kind of the baseline questions here. And so then the top 3 takeaways that we boiled down, I think this is the most important. If you get nothing else from this session, these 3 umbrella terms I think are most important. That picture there, infographic there, recapitulates what we're asking folks to use as it pertains to those 3 umbrella terms. And so Chad, I don't know if you want to rattle them off one more time.
Sure. Yeah. So biomarker testing, that is the type of potentially NGS screening or other type of testing that will check for proteins in your blood or other biomarkers shed from the tumor.
What if I want Ca125 testing? How would that work?
Sure, you ask for biomarker testing for Ca125. That is another type of biomarker test. If you're a little bit more specific, it really, that precision helps your provider know exactly what you're looking for. And then we have the other side of the coin, which would be genetic testing for inherited mutations, and that's your what we have typically talked about as a germline test, and that will really help you determine what your inherited risk is, what you have really had since you were a baby in your bloodstream, so that you can make determinations on that side of care as well.
Great, thank you. All right, so this really wraps it up. I think that I'll tell you, full disclosure, we found ourselves, and we've been working on a bill in Congress for a couple of years now that should drop hopefully in the next couple of months. But the idea was to expand insurance coverage for all of these types of testing for our patient population, because our dog in this fight is pretty big. Ovarian cancer, the opportunity when it comes to precision oncology is really, really exciting, just because they account for such a big, relatively speaking, incidence of ovarian cancer cases. But language is critical. It's our most important tool for communication. If we're not speaking the same language, we fundamentally can't communicate. So in thinking about what that legislation would look like and how we would go about writing it, we were like, wait a second, we're putting the cart before the horse here, because we don't even have agreed upon shared terms that we use across stakeholders in the health space. So we joined with Longevity in these efforts because it is so important. It really is, language is everything.
Yeah, that's right. And particularly when writing effective health policy, one of the most important thing to do is ensure proper definitions. If you can define things properly in the law, you can make sure that it's covered, not just now, but in years to come. And so I think it was important to pause and make sure we had everything right for moving forward with this legislation. Incidentally, not only do we want to increase coverage for these types of testing, but we're also looking to allow some funds for education, but for both provider and patients, so that we can make sure that this type of information is more readily available to everybody in the care continuum. Make sure we're all speaking the right language and know what coverage is available, and make sure that everyone's getting the testing that they need to ensure proper treatment.
That's right. That's right. And so there will be more to come on our website about all of this, different tools and resources. I highly encourage everyone to check out the working group website and to keep checking back for updates, because the second piece of this, of course, now that we have this common language, these three umbrella terms, is really pulling them into the mainstream. And then, of course, ensuring that coverage is robust enough to cover it, and doing all of those things, pushing all the other levers. So anyway, please don't hesitate to reach out to me or Chad with any related questions or suggestions, yes, or if anything was unclear. Again, don't be shy, because if we can't even talk about this stuff, then we really can't proceed with being sure that everyone who needs it is getting the proper kind of
That's testing. Right. And depending on when you're watching this, Vanessa and I will be doing a live session as well, with some office hours. So you may be able to come pop over into that room and ask us your questions live. Hopefully we'll be able to answer them. But if not, please, as Vanessa said, don't hesitate to send us an email, and we'll be very responsive to that.
That's right.
Thank you very much for joining us. Vanessa, do you have any last things to share?
No, I think that's it. Thank you.
Great. Hope you enjoy the rest of the conference, and thanks for spending some time with us.